We're ready to start. Thank you.
Thank you, Nimu. Hello, everybody. Welcome to Medicine for Members, which today is about the artificial pancreas work going on at Addenbrooke's Hospital, which is one of the most exciting projects that's taking place at the moment. I'd like to thank all of our members for joining us today, and anybody who's a guest. You're very welcome to become members of the Foundation Trust. And all you have to do is go to the Addenbrooke's website, which is www.cuh.nhs.uk. Today, I'm hosting my first Medicine for Members. I have the great privilege of being a public governor of the hospital. And in my day job, I look after the fundraising team at Addenbrooke's Charitable Trust, which is the hospital's charity. I'm delighted to be here today amongst a great company who are going to tell us all about the artificial pancreas work and how that research translates into incredible patient care. So first of all, we have Dr. Charlotte Boughton, who's a clinical lecturer at the University of Cambridge. And then we have Sara Hartnell, who's a principal diabetes dietitian at the hospital. And then we're delighted to welcome Fiona, who is joining us to tell us what it's like from a patient perspective. So she has benefited from using the artificial pancreas. If you have questions as we go along, as I'm sure you will, please use the Q&A function if you're joining us on Zoom. Otherwise, please comment on Facebook. The chat function is going to be disabled on Zoom. So if you want us to see your question, please use the Q&A. And now I'm delighted to hand over to Charlotte.
Thanks very much, Gemma. I'm just going to share my screen. And hopefully you can see the slides now. Brilliant, thank you. So thanks ever so much for inviting us to join you this evening to talk about an artificial pancreas for people with type 2 diabetes and whether this is the future. And hopefully we can shed some light on that over the next 30 minutes. So over the next 30 minutes, we're going to cover what is an artificial pancreas and how does it work? And we'll touch a little bit on the progress that's been made for people with type 1 diabetes, because that's also made the news recently. But really, we wanted to focus this section on sort of an upcoming and exciting area, which is closed loop systems for people with type 2 diabetes. And we look at the use of the system in the hospital, in those people with type 2 diabetes requiring dialysis, and most recently, those with type 2 diabetes not requiring dialysis. So the first poll to get you engaged with the talk and get your brains going, I've got 6 pictures here of potential artificial pancreases, and what we'd like you to do, if that's okay, is to vote in the Q&A with either 1, 2, 3, 4, 5, or 6. I'd like to say there's no wrong answers, but that's not necessarily the case. So don't be shy in coming forward. And we'll give you about 10 seconds to vote now. And so far we're 100% voting for number 3. So you're absolutely correct. So number 3 is an artificial pancreas. Incidentally, number 2 is the first ever insulin pump that was developed. So shows how things have progressed in terms of diabetes technology overall. I personally quite like number 5. So what makes up an artificial pancreas, which is also known as a closed loop system? So there tends to be 3 components. So one is a continuous glucose monitor or sensor, which measures glucose levels around the fluid in the cells, and that's worn just underneath the skin, as you can see in the picture on the left. There's then the second component is an insulin pump. So this is attached to the body by a thin bit of tubing, or you can get patch pumps, which don't have the tubing. And this delivers continuously rapid acting insulin. And the third part, which is the most important part for a closed loop system, is the controller or closed loop algorithm. And it's basically a computer program. In the case of the closed loop system that's been developed by Professor Roman Havorka at the University of Cambridge, this is an app on an Android smartphone. And the phone can be used for other purposes as well. So it's an unlocked smartphone. And this is what is the sort of brains behind the system, is the algorithm. So how does a closed loop system work? Well, every 5 minutes, a glucose level is sent from the glucose sensor to the control algorithm. The control algorithm then calculates the amount of insulin that's going to be required to keep the glucose within the target range or the desired range. And it automatically directs the insulin pump to give this correct amount of insulin. And that can be adjusted every 10 to 12 minutes. So this is a constant cycle of as the glucose levels change, so the higher the glucose, the more insulin the algorithm will direct the pump to give. And it occurs automatically. So the devices communicate via Bluetooth, and so provided they're all within 6 meters or 10 meters of each other, then the system works without interruption. Over the last sort of 15 years, there's been an awful lot of research for closed loop systems for people with type 1 diabetes. And this isn't really the focus of what we're doing today, but it's really transformed management of type 1 diabetes. These are called hybrid closed loop systems, and we won't go into this too much, but what it basically means is it's not a fully automated system. So users have to still count the number of carbohydrates they're consuming and then administer insulin in response to that. But these studies have shown that closed loop systems can improve glucose control. So people using them spend more time with glucose in the target glucose range. And they also reduce the risk of low glucose levels or hypoglycemia. And they've also been shown to significantly improve quality of life. So we've done lots of research studies at the University of Cambridge, and you can see that some of our participants here, from the very young children with type 1 diabetes all the way to the older adults with type 1 diabetes, and everything in between, including pregnant women. So moving on to our second poll here. I mentioned that closed loop systems help people keep the glucose within the target glucose range. And this is something that Sara is going to describe a little bit after this poll. But just out of curiosity, what do you think the target glucose range is for people with diabetes? So is it number 1, less than 12 millimoles, number 2, greater than 4 millimoles per litre, 3, between 4 and 10 millimoles per litre, or 4, between 3 and 16 millimole per litre? I'll give you 10 seconds to vote now. Brilliant. So there's a bit of a split between number 3 and 4. So I'll hand you over to Sara, who'll take you through this now.
Thanks, Charlotte. So yeah, historically, we've looked at how well someone manages their diabetes in terms of measuring their HbA1c, but that's not actually a great measure because it doesn't tell you much about kind of the ups and downs. It kind of just gives an average. So it's fantastic now to have systems where we can look and see what the glucose levels are doing all the time and measure glucose in terms of time in target glucose range. So a consensus guideline from 2019 encourages us to aim for 70% of more of the time, 70% or more of time in the target range of between 3.9 and 10 millimoles per litre. So that was the answer to your previous question. Crucially though, with less than 5% time in total below 3.9. So we want a good amount of time in range, but without it impacting on levels of hypoglycemia. Thank you, next slide. But clearly management of diabetes is far more than just about the numbers, and it's really important to consider the sort of quality of life issues alongside. And this just highlights that with some quotes from parents of young children using our hybrid closed loop system to manage their type 1 diabetes. And you can see in terms of quality of life, a big impact all round in terms of confidence in managing, reduction in hypos, particularly with people feeling more able to sleep soundly at night, which is fantastic, as well as obviously hopefully improved glucose control. Next slide, thank you. And in the UK currently, there are a number of commercially available hybrid closed loop systems, more and more coming all the time. And here's just a selection of them. There's the Medtronic system on the left-hand side, the Tandem T-Slim with Control IQ in the middle there, and our Cambridge system that's been developed here by the University of Cambridge on the right-hand side there. And what's so great currently is there is choice and more choice coming all the time. Next slide, thank you. And you might have noticed that these systems are starting to make the headlines. So currently NHS England has funded a national pilot to try and see if the excellent research outcomes that we've seen and been involved in can be replicated in the real world, really, and can help hopefully to inform NICE's decision making in terms of funding going forward. So there's been lots of articles published recently, and actually our Cambridge system was featured on the One Show on Tuesday yesterday, which was exciting. Next slide, thanks.
So moving on to closed loop systems for people with type 2 diabetes, which is really an evolving area. And we're going to start by looking at the evidence for closed loop systems in the hospital. So time for a third poll. How many people in hospital do you think have diabetes at any one time? So is it 0 to 10% of beds are occupied by someone with diabetes, 10 to 20%, 20 to 40%, or over 40%? Brilliant. So the polls get harder as we go through, so beware the end. So we've got a bit more indecision about this, people hovering between 2 and 3. So we have the National Diabetes Inpatient Audit of hospitals in England, and this is a snapshot audit which reports outcomes and the way that diabetes in the hospital is managed. And this report includes information on over 16,000 people with diabetes in hospital. And on average, that's 18%. So 1 in 6 of all people in hospital have diabetes. And in some hospitals, this is as high as 25%, so 1 in 4, and likely to increase. So what we do know from various different reports, including this statement from Diabetes UK, is that inpatients with diabetes have higher rates of infection, approximately 3 days longer length of stay, higher readmission rates, and 6.4% higher risk of mortality than people without diabetes. There are a number of issues with the way that we manage diabetes in hospital at present. So almost a third of inpatient medication charts have at least one medication error. We've got 18% of inpatients with diabetes having a hypo or low glucose level during their admission, 1.4% with diabetes requiring injectable rescue therapy for a severe hypoglycemia, and between 0.2 to 3.6% of inpatients with diabetes developing a hypoglycemic emergency whilst they're in hospital. And inpatient diabetes care is consuming a large proportion of the NHS budget already. So 2.5 billion, which equates to 11% of the entire inpatient budget, is spent on inpatient diabetes care. And the outcome of this consensus statement from Diabetes UK was that we can and must do better for people with diabetes in hospital. So we believe that this is the answer moving forward. So CAMAPS HX was developed at the University of Cambridge and is a fully automated insulin delivery system, so requires no input from the user at all. It has an adjustable target glucose level, which can be customized to suit the individual patient, and comes with alarms for both hypo and hyperglycemia. And you're able to see the data remotely, which can be really helpful for diabetes teams. This is the sort of data that we can see. So in the red line here, this is the continuous glucose monitor or glucose sensor data. And you can see that this sort of fluctuates up and down over the course of the day. In response to the fluctuations, you can see in the bottom there, the thin blue line, and this is the automatic delivery of insulin in response to the glucose levels. So as the glucose levels start to rise after midday, so do the insulin levels. Whereas at sort of 6 o'clock, as glucose levels starts to fall, the insulin delivery completely suspends. And so you can see how this works in an automated fashion. So we wanted to do a study to see whether fully closed loop insulin delivery is actually better than standard insulin therapy in hospital. So we did a randomized controlled trial, which included 136 inpatients who had inpatient hyperglycemia requiring insulin. So these were people with type 2 diabetes or stress hyperglycemia. And they were randomized. So half of the people in the study continued with standard insulin therapy. They did wear a mask sensor so that we could collect the information about their glucose control. And the other half of the participants in the study used the fully automated closed loop system. And this continued for up to 15 days or until people were discharged from hospital, whichever occurred sooner. So this was published in the New England Journal of Medicine. And really the results were astounding. So closed loop system, those who were wearing this spent on average 24 percentage points more time with glucose in the target range compared to the usual care. So to put this into sort of more tangible numbers, this is 6 additional hours each day with glucose in target. They had much lower mean glucose levels, and this was achieved without increasing the risk of hypoglycemia. This graph here really just shows the difference between the two therapies. So in the brown line and shaded area is the glucose control in those who use the closed loop system. And you can see the vast majority of this is between the target glucose range, which is the horizontal lines. Whereas in the conventional insulin delivery, the glucose levels are on average much higher and with much greater time above target range. This graph here on the right just shows the work that the system is doing to keep the glucose in that range. So this is the variability of the automated insulin delivery system that you can see here, and the sort of work that's going on behind the scenes to achieve the improved glucose control. Importantly, we needed to know whether the device was safe, and there were no severe hypos or other serious adverse events in the closed loop group, which was reassuring. And actually, there was a reduction in the number of significant hyperglycemic events. So this is really important. And equally as importantly, was it acceptable? Were patients okay with wearing it? So you can see that the vast majority of patients were very happy wearing the system, and all of the respondents to the survey would recommend the system to a friend or family member if they were in hospital. So I'm going to move on to Sara now.
Thank you. So moving on from that study, what we wanted to do was kind of push the system a little bit and utilize it with patients who are notoriously difficult to manage the glucose levels with. So those receiving artificial nutrition support, so either requiring an enteral feed, so like a tube feed, or a parenteral feed, which is when you provide nutrition directly into the veins, like IV nutrition, if you like. And so the same study design as previously, and again, some fantastic outcome data from this, with 32% more time with the glucose in the target range compared to the usual care group, which equates to a significant 8 hours additional hours each day in that target range. Crucially though, with no increased risk of hypoglycemia. Next slide, thanks. And again, you can see this really nicely in the graph form here. So again, the closed loop group in the red, and you can see almost nearly all with that time in the target range band that you can see. Thank you. Next slide. And so from this, from these two studies, we realized that we'd had amongst this patient cohort a number of patients who were requiring hemodialysis during their time in hospital. And this, again, is another notoriously difficult group of patients to manage glucose levels with. And so out of that group, we had 17 patients that were having hemodialysis. And of them, when we had a look at the data, 9 of them had been randomized to the closed loop insulin delivery arm, and 8 were receiving, we had the data for their control data for their normal usual care. Thank you. Next slide. And again, what you can see is similarly impressive results, maybe even more so. So you can see there the time in the target range of the control of the closed loop group in the red there was significantly improved compared to the grey band of the control arm, and that equated to a 38% increased time in the target range. So an additional 9 hours per day spent in that band with lower mean glucose levels, and again, no increased risk of hypoglycemia, which is so crucial with these patients in hospital. So to conclude from these studies, we have established that fully closed loop insulin delivery in patients is safe and significantly improves glucose control without increasing the risk of hypoglycemia compared to the normal insulin therapy in both patients requiring nutrition support and in patients requiring hemodialysis. Thank you. So what were the next steps? What we wanted to do then is go on to, again, translate this research into the real world, really. And off the back of these studies, the CAMAPS-HX system was licensed for use in hospitals. So with the support of the Addenbrooke's Charitable Trust, for which we're very grateful, we are in the middle currently of an implementation pilot to utilise some funded systems on our inpatients in hospital currently. And as part of this work, we've looked at various requirements, including training, and developed an online module for healthcare professionals to do the training online really easily. And moving on from that, you can see there's this was our global first. This was the first ever patient that used artificial pancreas system to manage glucose as an inpatient in a hospital anywhere in the world, and we were very pleased to be tweeting about that because it was really exciting. So a question for you all. Having seen the data so far, we're interested to know that if you had diabetes requiring insulin and were admitted to hospital, would you want to use a closed loop system? So 1, absolutely yes, 100%. 2, definitely not. Or 3, we've not convinced you yet, you're not sure. So lots of ones, fantastic. So in terms of where we go next with this, I guess the unanswered question is, looking in back at that data Charlotte provided in terms of the costs associated with managing inpatient diabetes, what we would like to see is if improving glucose control using an artificial pancreas when in hospital could improve health outcomes and reduce length of stay for people with diabetes, but that would take a much bigger study for which we're interested in looking into over the next couple of years.
So we're moving now from the inpatient setting into an outpatient setting. And because of the data which Sara explained about the benefits that we saw in inpatients who require dialysis, we thought this was a natural step. So we started the AP Renal Study just over a year ago now. And we know that diabetes is the commonest cause of kidney failure, accounting for about 30% of cases. And there are many oral diabetes medications which aren't approved in people with kidney failure. So insulin is very commonly used in this population. And both kidney failure itself and dialysis can increase the risk of low and high glucose levels. So the AP Renal Study compared the fully automated closed loop system you've been hearing about with people's standard insulin therapy that they were using prior to the study. And we included adults with type 2 diabetes who were on insulin therapy and had kidney failure requiring dialysis. After randomization, the participants completed 20 days with the closed loop system using an ultra rapid insulin, then underwent a washout period before switching to their standard insulin therapy. And both of these periods were for 20 days, during which time they attended dialysis as their usual care. And you're probably getting familiar with these graphs now. So again, in the pink shaded area is the closed loop glucose control compared to the gray area, which is the control group's glucose control. And in this study, we saw 3.5 additional hours each day with glucose in the target range compared to usual care. And really importantly in this study, the participants spent less time in hypoglycemia, so with low glucose levels and lower average glucose levels.
So one of the cases, just to kind of highlight to you, was a 53-year-old lady who had had diabetes for 25 years and despite best efforts had a long history of suboptimal control. And so from that was registered blind due to diabetic retinopathy, had kidney failure requiring dialysis, and also ischemic heart disease and peripheral vascular disease. And her husband was her main carer, but because he worked, this lady required district nursing once a day to help with monitoring her glucose and administering her insulin when her husband was out. So her total daily insulin dose was 88 units a day, but she had that over 5 injections, as you can see there. Next slide, thank you. So this is a visual of kind of how her control looked with her normal care. So you can see there quite wide variability in her glucose levels, lots of highs and lows. And you can see more than 80% of the time was spent above that target range, so above 10 millimoles per litre, only managing to get 20% of her time within that 3.9 to 10 millimole per litre range. Next slide, thank you. And in comparison, this was her control using the closed loop system. So her total daily dose had reduced slightly with the closed loop system to 80 units a day, even though her control had improved greatly. And what you can see here is that her time in target increased dramatically with only now 28% in the above target range compared to where it was before. So 71% compared to the 20% in that target range, which is absolutely fantastic. Next slide, thank you. And so as well as kind of the figures that obviously we're really interested in, there was no increase in hypoglycemia and no increase in the amount of insulin, but there was also significant of sort of quality of life gains as well. So increased confidence with managing hypoglycemia due to having the alarms with the continuous glucose monitoring system. And she felt better generally. Her energy levels were improved, she said, and also the benefit of having fewer injections and no need for finger prick glucose checks. And again, something to consider is that this lady, that while she was on the system, didn't need to have the district nurse visits in the evenings because the system was doing all the work for us. Next slide, thank you. So in conclusion, Closedloop has been shown to improve glucose control in this group. So overall, on average, by 3.5 hours a day, with reduced hypoglycemia in this group of adults requiring type 2 diabetes requiring dialysis. So we've concluded that Closedloop was safe. It was associated with very low time in the hypoglycemic range in this very vulnerable population, and that a fully closed loop approach may be beneficial to the wider population with type 2 diabetes.
Thanks, Sara. So we're now moving on to a currently sort of active study that we're doing at the moment, which is looking at closed loop for people with type 2 diabetes who don't require dialysis for the reasons that Sara described. So this is phase 2 of the previous study that you saw. And the aim is to compare closed loop with standard insulin therapy for people with type 2 diabetes who don't require dialysis over a period of 8 weeks at home. And we're nearly completed recruitment for this study, which is we've got 29 participants enrolled. And we've had some amazing anecdotal individual experiences, which extend beyond the glycemic control, which we obviously haven't looked at yet. But these include things like improved neuropathy, reduced fatigue. Lots of people report increased energy levels. And there's also an educational and behavioral impact of seeing glucose levels all the time and how that changes things. But it's all very well hearing this all from us, but what does it actually really mean to wear a closed loop system? And we're really lucky to have Fiona here, who has been a participant in the phase 2 study, who's going to share with us her experience of using the closed loop system over the summer.
Okay, so thank you very much for inviting me to come and talk about it. I think Charlotte knows how excited I was about it all and how excited I still am about it. So just a little bit about me. I'm 59, and despite my age and the way I look, my favourite hobby is motorbike riding, and in the summer, using the closed loop system at the time, I did a 1,500-mile motorbike ride down the west coast of Ireland. But I do more extreme motorbike riding. I do off-road trail riding, so that includes lots of big rocky hills and mud trails. And I also sidecar passenger, which means standing on a platform and doing some quite extreme energetic work there. I work as a speech and language therapist. I travel to lots of different schools across Cambridgeshire, and a very busy, quite stressful job. Since COVID, I've been working mainly at home, which brings its own challenges, and I'm sure some of you all know. So just a little bit about my diabetes. I've had diabetes since my early 40s. Obviously, I'm type 2. I had a lot of difficulty accepting the diagnosis and understanding the seriousness of it, which led in the first 10 years or so of a real lack of control. And at times my blood glucose, my HbA1c was really high, and I just didn't have any awareness of what that was doing to me. I went very quickly from triple therapies of medication to insulin use. I had all sorts of related issues like mental health difficulties, anxiety, depression, feeling of hopelessness, sleep difficulties, anger, why me, I can't get control. And then I started to get some secondary complications, which medical professionals perhaps couldn't see and recognize, but I knew there was differences in my toes, so numbness in my big toe, and I had some neuropathy, in my toes too. So at night, particularly pain in some of my toes, and I just thought, I've got to change. This has got to change. So I had a lot of support from the community team, from dietitian, from a diabetic nurse, and from Adam Brooks. Then that didn't work, so I went to then got referred to Adam Brooks.
I'm sorry,
I had some great education. I was lucky enough to do the Daphne course because I was getting some hypos, and that really helped me start to understand diabetes and what it meant for me. I was referred also to mental health services for cognitive behavioural therapy. So I've been really, really lucky, and I think I've had an awful lot of support over the last few years for my diabetes. But none of it helped me. Nothing helped control it. Nothing helped get it sort of to where I wanted it. And my numbers still range between the 60s and 70s. I was up and down. I'd go up to sort of 72 and then come back down to 62 and then back up to 70. I just couldn't get control of it. I looked at low carb diets, and yeah, that helped. That really reduced my numbers. And actually, before I started the trial, through low carb diet, I managed to get down to 52, which was one of the lowest numbers I'd had, at all ever. So Charlotte asked me to talk to you about the pros and cons, and for me, I don't see any cons. I'm diabetic, I have no functioning pancreas, and I don't produce any influence myself, so I need to take insulin. So, you know, what would the cons be to having an artificial pancreas? I mean, let me start with the pros. It gave me so much more freedom just to be me and just to do me. I could ride my motorbike and do that extreme riding without any worry of finger pricking and injecting, stopping the group I was with. You know, was it a clean environment to inject? How did I get all my motorbike gear off to inject my insulin? You know, when you're group riding, having to stop every 2 hours to finger prick, that all stopped. My blood sugar was generally within the normal range, and I was really strict on myself. I really wanted it to be within the normal range, and with that continuous monitoring and the pump regularly injecting small amounts of insulin, and you can kind of hear it sort of makes a little hissing noise as it's going in, so you know that it's there working for you all day long. And it was just small amounts that I was having to have, but it was a continuous hissing. So, you know, almost throughout the day, I was getting 2-3 units of insulin as and when I needed it, which of course you cannot simulate when you're doing it for yourself. You just can't, particularly the way I work and my hobbies. It's almost impossible in a stressful job where I just don't think of it. I don't think of it for hours, and then I look and my numbers are really high. So actually having, you know, having that control with the pump was absolutely brilliant. And the alarms were great as well. I didn't get too high alarms because I'm really proud to say that I was in target 100% of the time practically whilst I was on the pump, which is just kind of fantastic for me. And the interesting things for me, the things I learned was that I only used 20 to 25 units of insulin on my non-working days. And actually, when I was having an extreme sport day, one day I only used 4 units of insulin in the whole 24-hour period. So that was just, you know, really a real eye-opener to me, because I just automatically was injecting 45 units of long-acting insulin every day. So I was always having that. And then on top of that, I was probably having another 30 to 50 units of fast-acting insulin before the pump. I think what it showed me was that the difference that work makes to my life, the stress that it causes, and I do need to retire very quickly before it kills me. So just quickly, because I know I'm running out of time, but the stigma of checking your blood sugars in public, of having to finger prick at a meal, at having to lift your top and inject, or inject the insulin, because I'm not one for going to the toilet to do it. I just do it at the table, but it still causes stigma. And there have been times when I haven't even wanted to inject and haven't injected insulin while I'm eating because of that stigma and because of those inevitable questions from people that you're out with. You know, oh, why are you doing that? Oh, what does diabetes mean? Why are you eating that then? Should you be eating that pudding if you've got diabetes? You know, all that kind of conversation that you know, I felt was really stigmatic. And actually with the pump, it's just so discreet, nobody knows, and you know, it's hidden. But the biggie for me, and I really didn't think it was going to reduce my HbA1c much, because actually I was already at, what was it, 52, something like that. It took it down to 44 in the 8 weeks that I was on it. So absolutely, I don't know, you know, absolutely huge for me. It was, it brought me to the pre-diabetic range. I've never been in the pre-diabetic range since diagnosis. But most of all, that sort of feeling, that general feeling of well-being. I wasn't exhausted, I wasn't fearful, and I felt that I could go anywhere and do anything. So the cons: having to change the insulin pump and the cannula every 3 to 4 days, carrying the reader and mobile everywhere, carrying the pump everywhere and finding a safe place to attach it to, and it always falling off and you having to kind of reattach it, having a cannula permanently attached to my body, having to pause it for a shower and then remembering to put it back on again. But honestly, compared to having to carry a blood sugar monitor and insulin and still not having proper control, I'd opt for the closed system any day. So Charlotte, if you want to give it back to me, that's fine. The biggest con of the trial for me was having to give it back, as you've probably got that message now. And Charlotte will tell you that she had to be very persuasive on the day she came to get it. And now it's, I think I gave it back around about the beginning of October. So it's just over sort of 4, 5, 6 weeks since I gave it back. I'm really struggling again to get my blood sugars under control. I'm always over 10, no matter how hard I try and what I try to do. So I think there's a huge impact on not having it, the physical complications. I've now got sleep difficulty again, exhaustion from sleep deprivation and the high blood sugars, anxiety and depression sort of rearing its ugly head again. And there's also that underlying fear always of secondary complications. Sorry, I'm getting upset. But what I'd like to say is thank you so much, Adam Brooks and Charlotte and Sara and all you guys working so hard to make a difference for us. It gave me a huge and better understanding of my diabetes, and it gives me hope for me and people like me, but particularly for those younger ones, and like that young child we saw on Tuesday on the One Show. And yeah, just brilliant work, and keep it up. Thank you very much.
Thanks, Fiona. That's amazing, open and honesty in your sort of experience with it. I'm really grateful for you sharing that with us, because it's not always easy to share as openly and as beautifully as you did. So thank you. And yeah, we really hope that the study that you're involved in will sort of move things forward to make this more accessible. And that's definitely something that's driving us here as well. So I guess it moves on to sort of our key take-home messages. And I think really actually what Fiona's talked about is sort of highlights really the take-home messages and the impact that this technology is having on individuals with type 2 diabetes. And I think we know that closed loop systems are already transforming the management of type 1 diabetes. We know that they're safe and can improve glucose control in inpatients with diabetes. And we're currently underway with implementation, which is being led by Adam Brooks, to make sure that this is reaching patient benefit. And that actually closed loop systems have shown benefit in people with type 2 diabetes and kidney failure who are requiring dialysis, and currently being evaluated in the wider population with type 2 diabetes requiring insulin. And we really feel that increased adoption of technology for people with type 2 diabetes is coming, but probably needs more emphasis on it. I think we're still quite far behind where we are with type 1 diabetes. And I think particularly Fiona's testimony sort of speaks about, actually, there's not a great deal of difference in terms of the effort, the workload of diabetes management between somebody with type 2 diabetes on insulin and someone with type 1 diabetes. So I think perhaps it's time to sort of equilibrate the adoption of technology within type 2 diabetes, as we've seen it be so successful in type 1 diabetes.
Charlotte, thank you. Fiona, Sara. Wow, that was so powerful. I knew that the project was impressive before joining, but you have blown my mind. And Fiona, I just want to say extra special thanks to you, because a lot of people don't realise how hard it is, and it's completely silent. It affects your days, your nights, all the bump you have to take with you everywhere. You know, having to go to the loo to inject, you shouldn't have to do that, but that is life with diabetes. I think you've spoken so bravely about it, and I thank you for dispelling some myths, because it doesn't matter whether you've got type 1 or type 2, it affects your life. And I think, you know, you're doing amazingly, so thanks for being so brave and talking. Charlotte and Sara, thank you so much. I think most of the questions we have in the Q&A are going to be for you, but you're going to have to tell me who's best placed to take them. If we can't answer the questions, what we'll do is get back to people via email, so that we have taken all questions while we're together. So first of all, we have a question from Roy, who asks, do patients with better controlled glucose levels undergo renal function improvement so they don't need hemodialysis any longer?
So I think this is a brilliant question. And of course, lots of people said, why are you doing this study initially in people with dialysis? We want to use closed loop in people before they even get to dialysis. And ultimately, that's the goal. At the moment, we haven't yet done a study that's looked at closed loop use for long enough to be able to see whether there's an improvement in kidney function, but it's really key to be able to demonstrate that improving glucose control earlier on can reduce the risk of long-term complications. And that's starting to be demonstrated a bit more so in type 1 diabetes, but obviously takes a long time to follow people up. So I think, yeah, it's going to be hugely important in terms of supporting widespread adoption of closed loop systems for people with type 2 diabetes as well.
Thank you. Next, we have a question from David, who says, thanks for this. Results are very encouraging. He's asking about the use of mobile phone technology, because he says it's really exciting, but it's not without its problems. Software can fail as phone manufacturers do system updates, and they can also be hacked. What's the thinking about long-term security?
Yes, I think for any regulated medical device, this all has to be demonstrated to be safe and secure from a regulatory perspective before it even reaches the market. So the beauty of doing something as an app on a phone is the sort of rapid innovation and updates that you can do to an app that can be implemented from one day to the next, rather than having some of our previous software, you had to bring back the pump to have the software updated. So there are certainly benefits and downsides to these things. But sort of from a reassuring point of view, I think the security has to be demonstrated to be robust. Of course, phones go missing, phones drop in all sorts of places, phones end up all over the place. We never cease to be amazed by what happens to phones. The backup system in this situation is that the pump is set to deliver a small amount of insulin, but not the amount that would be given via an automated system. So if the phone disappears, then the pump continues to give just a small amount of insulin until it's sort of reunited with its owner.
We have it's more of a comment than a question next. So we're joined by Professor Chris Watson, who's doing his own sterling work in the transplant team. He says, congratulations on your fabulous work and great results. I run the hospital's pancreas transplant program for diabetics with renal failure who need a kidney transplant. Do I need to find a new job?
I hope so. That would be a true success, I'm afraid.
I've had the pleasure of working with Chris over many years, and they are doing sterling work in the transplant team, so world leading. So to get that praise from your fellow colleagues is lovely. The next question we have is from Sani, who says, fantastic work. How much does it cost, and what will be required to make it accessible to all of those with challenging diabetes?
Yeah, I think that's the cost is obviously something that needs to be considered. So on average, if you look, it costs about, to run one of these systems with all the bits included, costs about £4,000 a year. And so I think cost is often one of the reasons why type 2 diabetes gets put on the back burner, because there's already a decent population of people with type 1 diabetes that kind of, from a sort of managing the cost point of view, is slightly more slightly easier, I guess. And then when you start to look at opening up this technology for use in people with type 2 diabetes, that's a much bigger population of people requiring insulin. So I think there's likely to be in the future, hopefully, some kind of criteria where those people who would get the most benefit maybe will be able to have access. And that's why we're trying to, all the research work that we do here in Cambridge is to try and provide evidence for reimbursement. So that's what we would like to see. But yeah, they're not cheap. So an insulin pump, which has a 4-year warranty on it, costs about £2,500, and then there's obviously the cost of the consumables and the sensors ongoing within that to run the systems, and the cost of the app itself. So
Amanda asks, sometimes rapid improvements in blood glucose control can worsen retinopathy. Have you seen any signs of this?
Yeah, thanks, Amanda. So the beauty of the system is that you can put a target glucose setting on it that's customizable to the individual. So certainly, and I think particularly within the NHS pilot for people with type 1 diabetes, to get included in the pilot, you need to have a higher HbA1c, so slightly suboptimal glycemic control. And I think in many of these patients in particular, we're using a higher glucose target to minimize the risk of developing retinopathy. We haven't seen particular signal in our studies, but they're relatively short periods of time, so 8 weeks, and we haven't seen anything at present, and I hope that continues to be the case. But we do warn people, and particularly if there's a concern about it, think about getting more frequent retinopathy checks just to make sure that that's not an issue. But I think certainly something to consider. Yeah, absolutely.
Retinopathy checks being another of the many appointments that people with diabetes have to have regularly. We have a question from Neil, who is our lead governor, who is asking why people can't keep the Closedloop kit after their trial.
A brilliant question. We would love to give it back to Fiona, and I think she's made a really compelling argument for why we should. And the devices that Fiona used are actually not at the moment approved. So being part of the trial is generating data to allow us to demonstrate to the regulators that this is safe and effective. So actually at the moment, we wouldn't be allowed, it doesn't have regulatory approval in an outpatient setting. So Sara mentioned earlier, the system that we use in the inpatient setting is licensed and can be used. But at the moment, what we would like to do is use the data from the study that Fiona's been in to be able to provide that to the regulators to make this commercially available for people with type 2 diabetes, because at the moment there's no licensed closed loop system for this population.
I think as a member of the public, I'm allowed to say that actually as a patient with diabetes, you're very lucky to be within Addenbrook's catchment, because you benefit from all of the translational research that's going on at the hospital. You're doing incredible work to keep your patients' blood glucose within the ranges. I think Fiona touched on one of the programmes, which is Daphne, which is used to be a week-long course that was looking at nutrition and helping patients to self-manage. You're helping other patients through running paediatric diabetes camps for newly diagnosed children, which helps them to learn how to control their condition and to realise that they're not alone. I think, Fiona, you're not alone. It's very lonely. It's a very lonely condition. But I would say that you're under the best care of Addenbrooks, and we're so lucky to have this team, and you guys are leading the way. So thank you for everything that you're doing. I think just having a little insight tonight into what you're doing is an absolute privilege. So as a final reminder, if anybody would like to become a member of the Foundation Trust, it is well worth doing. You get to hear brilliant people like Charlotte, Sara and Fiona talking about the amazing work going on at Addenbrooks. I'd highly recommend it. And just to say a final thank you to all three of them for speaking tonight. I will certainly be sharing this on social media afterwards, and I will be looking up the One Show because I missed that and it sounds like it was a good watch. So thank you very much, everybody. Good night.
Thank you.